Hi, I'm Christy Vath. I'm a physician assistant in Seattle, Washington at Seattle Rheumatology Associates. Today, we're talking FAQs and specifically, what does minimal disease activity mean in psoriatic arthritis, and how does deucravacitinib perform when evaluating this outcome at 52 weeks? So let's first discuss a bit of history. In 1998, we really had a drastic change in the way we treated patients with the approval of the first targeted biologic. So in the last 28 years, we've seen increasing number of targeted therapies that have allowed us to profoundly reduce disease activity and disability. As a result, this has created a need to develop objective treatment outcomes. The concept of minimal disease activity was first defined in rheumatoid arthritis in 2005 by the OMERACT working group. It has since been superseded by more stringent remission criteria. Unfortunately, the development of MDA in psoriatic arthritis lagged a bit behind, in part due to the heterogeneous multi-domain nature of the disease. So it was first developed in 2010 by Coates, Franson, and Helliwell through an expert consensus process. MDA has been validated as both a treatment target and outcome measure in psoriatic arthritis, with the landmark TCOPA trial demonstrating that tight control targeting MDA significantly improved ACR responses, PASI scores, and patient-reported outcomes compared to standard care. So what does psoriatic arthritis minimal disease activity encompass? It requires 5 of 7 criteria, and the 7 criteria include a tender joint count, swollen joint count, both need to be less than or equal to 1. PASI needs to be less than or equal to 1, or a body surface area less than or equal to 3%. There's also the patient pain and the patient global VAS. In the pain, it needs to be less than or equal to 15, and in the global, less than or equal to 20. And the HAQ-DI, which should be less than or equal to 0.5. And finally, tender enthesial points need to be less than or equal to 1. So now that we have validated measures with the goal of treat to target, let's talk therapy, specifically about deucravacitinib and how it performs in reaching MDA. So we know that deucravacitinib mechanism as a selective TYK2 inhibitor is in the JAK family, but it's very specific and only targets TYK2. So it impacts inflammatory pathways central to psoriatic arthritis pathogenesis, including IL-23 and type 1 interferon. The phase 3 trials, so there was POETYK PsA-1 and POETYK PsA-2 enrolled over 1,200 patients and demonstrate consistent efficacy regardless of prior exposure to biologics, concomitant DMARD use, or baseline characteristics. MDA response was a secondary endpoint in the trials with deucravacitinib, but it was found to be superior to placebo at week 16. An abstract presented at ACR Convergence in 2005 reported responses continued to improve through week 24 and were maintained at week 52. So at week 52, responses for deucravacitinib was nearly 34%. So you may think to yourself, well, how might that compare with other available therapies? And while there are no head-to-head studies and these can't be compared directly, I'm just going to give you some numbers so you have a ballpark. So for instance, at week 52, MDA response for ixekizumab was between 40 and 45%. And for upadacitinib, a JAK inhibitor, week 24 MDA was about 36%. So while we did not talk about safety, it's all something we think about when we think about treating our patients. And the great thing about deucravacitinib is there's no boxed warning for MACE or VTE like the other JAK inhibitors. So I think having another effective option with a novel MOA will only add to our ability to effectively treat our patients. Thanks again for joining me. And for more FAQs, go to the RAP website or ASAP. Have a good day.